So the document we're looking at today, it really pushes back against this whole idea that technology is always the answer in medicine.
Mm-hmm. The technological imperative.
Exactly. I mean, usually when you talk about organ failure,
Mm.
right, the conversation, it just immediately jumps for replacement. If your heart fails, you look at pumps. Lungs fail, ventilators.
Right.
And when the kidneys fail, the default, it's almost a reflex, is dialysis. But this document we're diving into, the 2025 Clinical Practice Guidelines on Conservative Kidney Management from the Malaysian Ministry of Health and the Academy of Medicine, it basically just puts a hard stop on that reflex.
It does.
It forces you to ask, is the machine always the medicine?
Mm-hmm.
Or is there a world where the best care actually means stepping away from the technology to treat the patient, not just their lab results?
That is such a critical question, and it's one that's getting more and more relevant, as our population gets older. We're talking specifically about advanced chronic kidney disease, CKD, so usually stage 4 and stage 5.
End of the road, basically.
Pretty much. And these guidelines you mentioned, they are incredibly comprehensive. They're not just some how-to guide for symptoms. They really represent a whole philosophical shift. They're validating this pathway called Conservative Kidney Management, or CKM.
CKM.
And let's be super clear right from the start, because this is the biggest misconception out there. CKM is not doing nothing.
Right. It's not giving up.
Not at all. It's not abandonment. It is a very active, medically intensive pathway that just happens to decline one specific intervention, dialysis.
That distinction feels so vital. I think for most people, the perception is you have two choices.
Mm.
You have dialysis, and that equals fighting. Or you have this conservative management, and that equals giving up.
Mm-hmm.
But when you read through the first section of these guidelines, the definition of CKM is incredibly robust. They call it holistic, patient-centered care for people with stage 5 CKD who either choose not to go down the kidney replacement path, or for whom dialysis is just not a good idea clinically.
Yeah, where it might do more harm than good.
Exactly. And the goals are laid out so clearly. Delay the disease progression, minimize the bad side effects, and, crucially, aggressively manage the symptoms. It really struck me as a pivot from, extension of life at all costs to optimization of the time that's left.
That's the perfect way to put it. It's about shifting the metric of success. I mean, in standard kidney care, nephrology, success is often measured by urea reduction ratios or your filtration rate, numbers on a chart.
Right.
In CKM, success is measured in symptom-free days or hospital-free days. And the guidelines are very, very specific about who this is for. We're not talking about a 30-year-old who has sudden kidney failure. No. This is designed for patients with poor functional status. Frailty is a word you see again and again in the text, or people with a lot of other significant health problems. We're talking severe heart failure, advanced cancer, end-stage liver disease.
And there's also a technical side to it, mentioned in the source, about hemodynamics. The idea that dialysis isn't this gentle, passive process. It's actually kind of violent for the cardiovascular system.
Oh, it's incredibly violent. Think about what hemodialysis is. You are pulling blood out of the body at a very high rate, running it through a filter, and then pushing it back in.
Mm-hmm.
That causes huge, rapid shifts in your body's fluid volume, your electrolytes. So if you have a patient who already has profound hypotension, chronically low blood pressure, or a heart that's really stiff and can't cope with those shifts,
The machine could just push them over the edge.
it can precipitate a crash. Absolutely. It can cause ischemia, a lack of blood flow to the gut, or even to the heart itself. In those cases, the guidelines basically argue that dialysis isn't just a bad choice. It's technically dangerous. It violates that core principle of medicine, primum non nocere.
First, do no harm.
First, do no harm.
And that leads right into the data on prognosis, which I have to say I found really counterintuitive. The fear that drives people away from CKM is this assumption that without dialysis, death is just days or weeks away.
Right. Imminent.
But the guidelines, they cite this big systematic review 41 cohort studies that paints a very, very different picture, especially for older patients.
This is the data point that completely changes the conversation. The review found that in patients over 75, and especially those with high comorbidity scores, meaning they have a lot of other sick organs, the survival advantage you get from dialysis compared to conservative management is often negligible.
Wow. Negligible.
We're talking about a difference of months, sometimes not even that. And then when you start to factor in the burden of therapy.
What does that mean exactly?
Well, it's the time you spend traveling to the dialysis center 3 days a week. It's the 4 hours you're physically hooked up to the machine. It's the recovery time afterwards, that dialysis hangover where you feel completely wiped out.
Right.
So when you add all that up, the actual time a patient spends living at home, feeling okay, can actually be higher in the conservative management group.
So the quantity of life might be statistically pretty similar, but the quality of that time, where you spend it, your autonomy is just worlds apart. And that gets us to the ethical framework the guidelines build all this on. They ground CKM in 4 big principles: autonomy, beneficence, non-maleficence, and justice. Now, autonomy is pretty straightforward, a patient's right to refuse treatment. But it's that interplay between beneficence acting in the patient's best interest and non-maleficence doing no harm. That's where the real intellectual weight of this document is.
It's the core tension, isn't it? I mean, for a very long time, nephrology just operated under this assumption that dialysis equals beneficence. We thought, okay, the kidneys are failing, the machine fixes that, therefore the machine is good for the patient.
It's the logical conclusion.
It seems like it, but these guidelines argue that for a frail patient, dialysis might actually be maleficence. It might be harmful. If the treatment causes pain, confusion, a total loss of independence, financial ruin, and it doesn't even significantly extend a meaningful life, are we really helping?
We'd be doing good.
Right, are we? The guidelines suggest that offering CKM is actually a way to fulfill our duty of non-maleficence. It protects the patient from that technological imperative that might actually be hurting them.
So to get through that ethical minefield, the source really champions this idea of shared decision-making, or SDM.
Yeah.
And this is not just a doctor getting a signature on a consent form.
No, not at all.
It describes this collaborative process, estimating the prognosis, sure, but then, crucially, eliciting the patient's values.
Right. And eliciting values is a real clinical skill. It's not just a chat. It's asking specific questions like, what is your biggest fear about all of this? Or is there something you're hoping to attend in the next 6 months? A graduation? A wedding?
Or even, where do you want to be when the end comes?
Exactly. And the guidelines link this directly to Advanced Care Planning, or ACP. There's this visual in the text, a timeline for ACP, and it makes it so clear that this conversation shouldn't be happening for the first time in the emergency room when the patient is crashing.
It needs to happen way earlier.
Way earlier. When the GFR, that's the glomerular filtration rate, a measure of kidney function, starts to decline significantly. That's the trigger.
So it's about turning the patient's personal goals into actual medical orders.
Yeah.
Things like a DNAR, a do not attempt resuscitation order, or their preferred place of death. It's really empowering the patient to draw the lines for their own care.
It is.
Okay, let's shift gears to the clinical side of this. The execution. If we agree that CKM is the chosen path, we still have to deal with the biological reality of kidney failure. The text calls it the symptom burden, and it sounds massive. These toxins build up and affect every single system in the body.
They do.
So let's start with the most common one, fatigue.
Overwhelming fatigue. And it's important to understand this isn't just being tired after a long day. This is a profound cellular lack of energy.
What's causing it?
It's mainly twofold. First, you have anemia. Your kidneys produce a hormone called erythropoietin, or EPO. That's the signal that tells your bone marrow to make red blood cells. As your kidney tissue dies off, your EPO levels just plummet, and your oxygen carrying capacity goes down with it. That's a huge part of the fatigue.
And the second part?
The second part is metabolic acidosis. The kidneys are supposed to get rid of the acid load from your diet. When they fail, your blood becomes acidic. And that acidic environment, it directly depresses your central nervous system and your muscle function. It just drains you.
So how do you manage that? The guidelines seem to blend pharmacology with something that looks a lot like occupational therapy.
I was really struck by the energy conservation strategies in Appendix 5.
Yeah, that's a concept they've borrowed from rehabilitation medicine. It's often called the 4 Ps. Prioritize, plan, pace, and posture.
The posture element was fascinatingly practical. The guidelines literally advise patients to sit to work.
I know, it sounds so simple, right?
Yeah. Sit to shave, sit to shower, sit to chop vegetables. But think about it. Standing is a hemodynamically expensive activity. It requires constant postural muscle tone, vascular resistance to keep blood from pooling in your legs. If your energy bank is almost empty, you don't want to spend what little you have on just standing upright.
They also mention sliding objects instead of lifting them.
It's all about mechanics. If you lift a heavy pot of water, you do what's called a Valsalva maneuver. You hold your breath and bear down. That spikes the pressure in your chest and demands a surge in cardiac output.
Which you just don't have.
You don't have it. Sliding that pot across the counter instead, it removes that strain completely. It's all about minimizing the metabolic cost of just getting through the day.
And then on the pharmacological side, they do treat the anemia, but the targets are really interesting. They use iron and these erythropoiesis-stimulating agents, ESAs, but they only aim for a hemoglobin of 8.5 to 10. That's still well below a healthy baseline.
It is, and that's very deliberate. We learned the hard way that trying to normalize hemoglobin in CKD patients using high doses of ESIs was actually linked to increased risks of stroke, blood clots, and high blood pressure.
Why?
The blood just becomes too thick, too viscous. So in CKM, we're not trying to turn them into an athlete. We're just trying to keep them above the threshold where they'd need a blood transfusion and to improve their symptoms. It's a Goldilocks zone.
Just right.
Exactly. Enough hemoglobin to get oxygen to the brain and feel better, but not so much that you start clotting your vessels.
Okay, let's move on to pain management. This is where the guidelines get really prescriptive, and you can see why. The standard painkillers that most of us reach for in our medicine cabinet NSAIDs like ibuprofen, naproxen,
Diclofenac
are all strictly contraindicated.
This is a non-negotiable in nephrology. It's one of the first things you learn. NSAIDs work by blocking something called prostaglandins. In the kidney, prostaglandins are what keep a key blood vessel dilated, the one that brings blood into the filter.
The efferent arteriole.
That's the one. So if you block that dilation in a kidney that's already struggling for blood flow, you basically clamp off its own blood supply. You can cause an acute kidney injury right on top of the chronic disease. You can wipe out whatever little function they had left. So, yeah, NSAIDs are out.
Completely off the table. So you start with paracetamol or acetaminophen, but when that's not enough, you have to move up the WHO analgesic ladder, and that means opioids. This is where the pharmacology gets really tricky. The guidelines are explicit about warning against morphine.
This is such a crucial teaching point. Morphine itself isn't the main problem. It's how your body processes it. The liver metabolizes it into two main byproducts, morphine-3 glucuronide, M3G, and morphine-6 glucuronide, M6G.
Okay.
Now, normally your kidneys just pee those out, but in stage 5 CKD, you can't. They just build up in the blood. M3G is neuroexcitatory. It causes muscle jerking, myoclonus, even seizures and agitation. And M6G is an even more potent opioid than morphine itself, so it causes profound sedation and respiratory depression.
So if you give a normal dose of morphine to a kidney patient,
They can end up in a coma or with severe neurotoxicity from the buildup. It's incredibly dangerous.
so what's the alternative? The source proposes fentanyl.
Correct. Fentanyl and methadone are the preferred strong opioids in this situation because they're primarily metabolized by the liver into inactive metabolites. They don't rely on the kidney to be cleared from the body. So for a patient in CKM with severe pain, a low-dose fentanyl patch is significantly safer than oral morphine. You completely bypass that renal excretion trap.
What about that burning, shooting kind of pain? The source mentions that neuropathic pain is really common.
That's often something called uremic neuropathy. The nerves themselves are actually damaged by the toxic environment in the blood. For that kind of pain, the guidelines recommend the gabapentinoids, so that's gabapentin or pregabalin, but, and this is a massive caveat, it's all about the dosing.
The phrase in the guidelines is start low and go slow.
I would say start very low. Gabapentin is 100% cleared by the kidneys. In a healthy person, you might prescribe 300 milligrams 3 times a day. In a CKM patient, we might start with 100 milligrams once every other day.
That's a huge difference.
Huge. If you overdose gabapentin in someone with renal failure, you get profound sedation and myoclonus, similar to the morphine toxicity. But when you dose it correctly, it's an absolute wonder drug because it treats the nerve pain and, as we're about to see, a bunch of other symptoms too.
Right. Speaking of other symptoms, let's talk about the itch. Uremic pruritus. The text says this affects nearly half of all patients. And it's not just, dry skin. It's coming from inside.
It is absolute torture for patients. It's relentless. It disrupts their sleep, which then worsens the fatigue, worsens the depression. The mechanism is really complex. It has to do with calcium and phosphate depositing in the skin, but also an imbalance in opioid receptors in the brain and general immune system chaos.
So how do you approach it?
The guidelines lay out a stepped approach. First, the simple stuff. Optimize the skin barrier. Use lots of thick, plain emollients to treat the xerosis, the dryness. Menthol creams can help by stimulating the cold receptors in the skin, which kind of distracts the nerves from the itch signal.
But when that's not enough, the systemic treatment leads us right back to gabapentin.
Exactly. Gabapentin seems to just quiet down that overactive sensory nerve transmission. It can be highly effective for uremic pruritus. The guidelines also make a point to mention the role of diet here, specifically phosphate. High serum phosphate is a major, major driver of the itch.
Which is the perfect segue into section 3, the gut and the diet. I feel like this is the part of the patient's life that just changes the most dramatically. The renal diet is kind of infamous for being incredibly restrictive, but the CKM guidelines, they refine the goal a bit. It's not about preserving the kidney for the next 20 years. It's about reducing the uremic toxicity that's making the patient feel sick right now.
It's a strategy of waste management, really. And the cornerstone recommendation is a low-protein diet. Specifically, they recommend 0.6 to 0.8 grams of protein per kilogram of ideal body weight per day.
Okay, so let's break down the mechanism there. Why does restricting protein reduce symptoms like nausea and confusion?
It's just basic biochemistry. When your body metabolizes protein, it produces nitrogen as a waste product. The liver takes that nitrogen and converts it into urea.
Right, which is what your kidneys are supposed to get rid of.
Exactly. Normally, you just pee it out. In CKD, the urea can't get out, so it builds up in your blood. And urea itself is the primary driver of what we call the uremic syndrome. That's the nausea, the metallic taste in your mouth, the brain fog, the general malaise. So by restricting the input of nitrogen, which is protein, you reduce the output of urea. It keeps the blood urea nitrogen at the BUN level lower, which directly correlates to the patient feeling less toxic.
The source also makes this distinction that feels very modern. It specifically prioritizes plant protein over animal protein. There's an appendix, Appendix 8, that highlights things like tofu, tempeh, and legumes.
This is a really significant evolution in renal nutrition. For years, the dogma was to push animal protein because it has what's called high biological value. But we now know that animal protein generates a much higher acid load, which worsens that metabolic acidosis we talked about. Plant proteins are generally alkaline forming. And then there's the huge issue of phosphate bioavailability.
The phytate factor, right?
Exactly. Plants store their phosphorus in a molecule called phytate. And humans, we lack the enzyme phytase in our gut to really break that down effectively. So if you eat 100 milligrams of phosphorus from a steak, you absorb pretty much all of it.
Okay.
If you eat 100 milligrams of phosphorus from, say, chickpeas, you only absorb about 40 to 50% of it. So plant proteins let patients eat a decent amount of food without spiking their phosphate levels, which helps control the itch and their bone disease. It's a huge win.
And then there's the salt and fluid restriction. The sodium limit is really strict, under 2 grams a day. And the fluid restriction, that often seems to be the hardest part for patients psychologically.
It's a constant battle against your body's own thirst mechanism. But it's absolutely necessary to prevent volume overload. If a patient is anuric, meaning they're not making any urine at all, then every single ounce of fluid they drink just stays in their body.
And where does it go?
It goes to the legs, causing edema. Then it backs up into the lungs, causing pulmonary edema. That feeling of breathlessness, of drowning, is terrifying for patients.
The flavor hacks section in Appendix 7 seems designed to address the palatability problem. I mean, low salt often just equals low flavor.
It does. So they suggest using fresh aromatics, things like lemongrass, garlic, ginger, lime, tamarind. These things stimulate your sense of smell and the sour and bitter taste buds, and that creates a more complex flavor profile that can distract you from the fact that there's no salt.
And there was that technique, dip, don't pour, for sauces.
Such a simple behavioral modification, but it works. By dipping your food, you coat the surface that hits your tongue first. You get the maximum sensory impact with the minimum sodium load. It's like a little way to cheat the system.
Let's talk about the GI symptoms more specifically, nausea and vomiting. The guidelines list specific anti-nausea medications.
Yeah, the nausea is usually caused by those uremic toxins stimulating a part of the brainstem called the chemoreceptor trigger zone, or CTZ. The guidelines recommend the 5-HT3 antagonists, like ondansetron, as a first line. They also mention metoclopramide, which is a dopamine antagonist that has the added benefit of promoting gastric emptying, which is really helpful if the patient also has diabetic gastroparesis.
And then there's constipation. This seems almost inevitable given all the restrictions. You're on low fluid, you're on low fiber because a lot of high-fiber fruits and vegetables are high in potassium.
And you're on iron supplements for your anemia and maybe opioids for your pain.
It's the perfect storm.
It really is. And constipation isn't just a comfort issue in CKM. It worsens the nausea, it causes bloating and poor appetite. So the guidelines are very clear that you have to be proactive. They mandate the use of laxatives like lactulose or bisacodil, but they include a really critical warning: avoid phosphate enemas.
Why is that? Is it because the rectal mucosa is highly absorptive?
Extremely absorptive. If you give a standard fleet enema, which is sodium phosphate, to a patient with renal failure, all of that phosphate gets absorbed very rapidly into their bloodstream. It can cause hyperphosphatemia so severe that it triggers a crash in calcium levels, leading to tetany, seizures, and cardiac arrest. It's a known killer in nephrology.
Wow. Okay. Moving on to section 4, the mind. The psychological impact of facing end-stage organ failure is obviously immense, but the source material does a great job of highlighting how the physical symptoms directly drive the mental distress. It says sleep disturbance affects up to 83% of these patients.
It's a vicious cycle. The itching, the pruritus keeps them awake. The anxiety about their condition keeps them awake. And then you have restless leg syndrome, or RLS.
I think a lot of people dismiss RLS as just fidgeting, but the description in the text sounds much more severe than that.
Oh, it is. Patients describe it as this unbearable, creepy-crawly sensation deep inside their leg muscles, or even like electric shocks. There's a strong link between RLS and iron deficiency in a specific part of the brain, the substantia nigra. So the very first step in management is to check their iron stores, their ferritin level.
And if the ferritin is low?
If it's low, iron replacement therapy can completely cure the RLS. It's amazing.
And if their iron levels are normal?
Then we return to our little Swiss Army knife gabapentin. It's highly effective for RLS as well.
Now, for depression and anxiety, the guidelines recommend non-drug approaches first: cognitive behavioral therapy, CBT, good sleep hygiene. But if medication is needed, there's a specific caution about using SSRIs like sertraline.
Yes. In general, SSRIs are safe to use, but sertraline in particular has a side effect profile that includes nausea and occasionally hyponatremia, which is low sodium.
Which is a problem.
It's a huge problem in a patient who is already nauseous from their uremia and is on a strict sodium and fluid restriction. Sertraline can just make the whole clinical picture worse. You might prefer something like mirtazapine instead, which has the added benefits of stimulating appetite and being sedating so it can help with sleep. You can solve 3 problems with 1 pill.
And so finally we reach section 5, the end of life. The language in the guidelines shifts here from management to active dying. It's described as a distinct physiological phase.
It is. This is typically what happens in the last 48 to 72 hours of life. The entire focus of care shifts away from management and entirely to comfort. And the signs are usually quite clear. A decreased level of consciousness, modeling of the skin, what we call levato reticularis from poor perfusion, and distinct changes in breathing patterns.
Specifically, they mention Cheyne-Stokes respiration.
That's the classic pattern. You'll see periods of deep, rapid breathing, followed by a period of apnea, a complete stop in breathing for maybe 20 or 30 seconds. It's caused by the brainstem's changing sensitivity to carbon dioxide levels in the blood. It can be incredibly frightening for the family to watch, but we don't believe it's painful or distressing for the patient.
Another symptom that's mentioned as being very distressing for the family is terminal secretions, the so-called death rattle.
This happens simply because the patient becomes too weak to swallow their own saliva or to cough effectively. The fluid just pools in the back of the throat and the hypopharynx, and the air moving over it causes that rattling sound.
How do you treat that?
We treat it with anticholinergic medications, drugs that dry up secretions, hyoscine butyl bromide, which is buscopan, or even atropine drops given under the tongue, are standard practice.
There's also a really significant discussion in this section on the hydration debate. I think the instinct for any family member watching a loved one die is to say, he's not drinking, he must be thirsty, give him an IV.
It's a completely natural and loving instinct.
But the guidelines suggest that this clinically assisted hydration in the dying phase might actually be counterproductive.
This is a really hard physiological reality to accept, but it's true. When the kidneys have completely shut down, they cannot excrete water. If you hang a bag of saline and run it in, that fluid has nowhere to go. It just stays in the body.
And that causes problems.
It leaks into the lungs, which worsens their breathlessness. It leaks into the bronchial tree, which worsens the death rattle. It causes painful peripheral edema. And there's even some evidence that the mild state of dehydration at the end of life leads to the release of endogenous opioids, the body's own natural endorphins, that might act as a sort of anesthetic, making the passing more peaceful.
So withholding fluids is, in a very real medical sense, a form of symptom management.
It is. It's about prioritizing the patient's respiratory comfort over the family's understandable desire to feed or hydrate.
The burden on the caregiver through all of this must be just immense. The source material actually acknowledges caregiver burden as its own clinical entity.
They essentially become the 24-hour nursing staff. They are managing the complex medication regimen, the incredibly restrictive diet, the hygiene, the positioning. There's an appendix, Appendix 10, that's focused just on training them, how to prevent pressure ulcers or bed sores through regular repositioning, how to provide good mouth care when the patient can no longer drink. CKM as a model simply cannot function without a well-supported, well-educated caregiver.
Stepping back now and just looking at the whole picture, these guidelines really map out this sophisticated ecosystem of care. It is so much more than just waiting to die. It is a meticulous pharmacological, dietary, and psychological strategy to live well with the time you have left.
That is the absolute essence of it. I love that the word palliative comes from the Latin word pallieo, which means to cloak. That's what CKM is. It's about cloaking the patient in protection from the violence of their unchecked symptoms, and protection from the burden of futile, painful interventions.
It really challenges us to redefine what bravery in medicine looks like. So often, we think bravery is about fighting the disease with every last machine we have. But maybe there's a different, quieter kind of bravery in recognizing when the technology no longer serves the human being and choosing the path of comfort and connection instead.
I think that's the ultimate takeaway. It's about making sure that our incredible medical capabilities are always aligned with our human goals. We often obsess over the technology of saving lives, the machines and the surgeries. But this guideline, it reminds us that sometimes the most sophisticated medicine is just meticulously managing a patient's comfort and really listening to their goals. The final question it leaves you with is, are we brave enough to choose quality over quantity when the time comes?
Thank you for unpacking all of this with me. It's a dense and difficult topic, but a really necessary one.
It was my pleasure.
Stay curious, take care of your kidneys. We'll see you on the next deep dive.